Thank you. Good evening, friends and chairpersons. In a forum like Avatar, where real high-tech things are either discussed or demonstrated, it may be out of place to talk on mundane ultrasound. And for a nephrologist to talk about ultrasound in front of eminent radiologists here, it may sound slightly audacious also. But I believe I have some messages to be given to young nephrologists who aspire to be interventional nephrologists. This is quite an old slide, just to highlight that nephrologist is one who doesn't use ultrasound much. But the times have changed, but we have many nephrologists using ultrasound now. And now we know that ultrasound, from being a tool by radiologists, has become a bedside tool for patient examination across specialties. But the maximum benefit has been derived by cardiologists rather than others. We know how strong they are in interventional cardiology, how they are usurping so many procedures from surgeons. I think the main reason or the strength is their adeptness in doing echocardiogram. And they have kept it close to the heart, not allowing others to do. And it will be very nice to see them use ultrasound along with their interventional procedures, especially when they do balloon valvuloplasty or device closure of ASC, etc. So likewise, I believe that nephrologists also should be familiar with ultrasound. See, there are, besides routine kidney size, echogenicity, collecting system assessment by ultrasound, there are so many other areas which I think I'll highlight today. And I won't be able to tell you the techniques and procedures, but just to impress you that these are all there and we should be going into it. And I, having started my practice in a faraway place where I started transplant in 1996, I had to learn Doppler tests for my transplant. And renal artery stenosis, we know that most of the available tests are not very sensitive, although some of them are specific. So anything short of angiogram, do not pick up this renal artery stenosis. And Doppler is often time consuming, and it is difficult to pick up the main renal artery in many obese patients. And radiologists in mobile centers are too busy to spend time on renal Doppler. So it was an advantage that I took up Doppler, and we know that renal artery stenosis is more often diagnosed by non-nephrologists by chance during other angiogram procedures. And even though we are not able to pick up the main renal artery, we can derive a lot of information from intrarenal branches where Parvus Stardust pattern can be easily picked up. And I have found that time to peak more than 100 milliseconds and acceleration time less than 100 milliseconds is a good indicator of renal artery stenosis. Not only presence of renal artery stenosis, but also reversibility. Whenever you have this pattern, you can make it sure that these lesions will be reversible after intervention. And this was presented in one of the meetings where I got this Doppler indices for diagnosis of renal artery stenosis. And this is a Doppler study before and after the interventions. And I had the opportunity to present nearly 50 cases of renal artery stenosis picked up by me in ASDIN in 2013. And this number might look big, but I believe that if nephrologists do Doppler exam, more undiagnosed cases will be picked up in a treatable stage. And also, renal transplant patients, transplant renal artery stenosis, although not very common, will be picked up in more numbers by us. And as I was doing Doppler for transplant kidney, I thought, why not do for acute kidney injury? After all, transplant rejection is a form of acute interstitial nephritis. So I tried doing this, and I found that there is a definite difference between the Doppler pattern in glomerular disease, where the renal failure could be severe, more or less normal looking Doppler, whereas in interstitial disease, the Doppler, there is increased resistive index, although the renal failure may not be severe. So it was very useful as a first tool to differentiate between glomerular disease and tubular interstitial disease by Doppler. And this I could present as early as 2003, ultrasound Doppler for ARF, a prospective study. And transplant dysfunction, we have to do by day-to-day Doppler, and we know that increased resistive index, absence of diastolic flow, reversal of diastolic flow, they all indicate renal graft dysfunction, but I believe that it doesn't show the cause. You will see that in this example, you see high resistive index with absent diastolic flow, and here there is very good, very prominent diastolic reversal. So anybody would say that this is a case of severe vascular or cellular rejection, but the biopsy turned out to be still ATN. So just to say that Doppler is not enough, so we need more tools to study this transplant kidneys. And elastography, a new technique which identifies the elasticity of the and compressibility of the tissues has come now, and it is often used for thyroid and breast. But transplant kidney being a superficial placed organ, it can be tried for transplant kidney. And it can be quantified, and you see that in a normal transplant kidney, if you take the sinus echoes, the sinus elasticity, sinus area just contains areolar tissue which is very soft, not affected by any of the pathological processes. If you compare that with the cortex, you see that there isn't much difference. But in disease, we can hypothesize that in calcineurin toxicity and ATN, where you expect vasoconstriction, some ischemia and necrosis, the kidney would go flaccid and it will be more elastic and less solid. In rejection, which is an acute interstitial nephritis, there is edema, cellular infiltration, and so the kidney becomes turgid. And in chronic allograft nephropathy, due to fibrosis, you expect the kidney to be tougher. So this difference in the pathological process can be showed by elastography, and you see that this is a case of acute rejection where you see it is stiffer or less elastic than the sinus echoes. And this is a case of calcineurin toxicity where you see that it is very soft, as soft as the sinus area. And this again another transplant patient, you see that the Doppler is very inadequate. It doesn't give any information, but you see the elastography is showing you increase in the stiffness. And this was presented in the WC in Mexico, where a preliminary report was given. Next usefulness is ultrasound guidance for procedures, which is being used by many nephrologists. But I want to warn you that you should understand that the probe and the needle should be placed in the right angle so that you get the tip properly. And also realize that only the reflected sound waves which reach the probe will be shown in the picture. So when the needle is like this, the ultrasound waves from here does not reach the probe, so you will realize that this is the tip in the picture, but actually the tip is further down. So you will have a tendency to overdo. And ultrasound will be useful in CIPD to identify the inferior epigastric artery so that you don't injure it during catheter placement. And you can also, to a certain extent, see that there is no peritoneal adhesion. And now, another area where the nephrologist's role has to be increased is critical care. Although, this is, we are underused in this area, and if you are adept in using ultrasound or point of care ultrasound, will be more involved, and many of our patients are critically ill, and it will be a very useful tool for nephrologists. And volume assessment by lung scan and IVC scan, IVC collapse, presence of pericardial effusion, pleural effusion, pneumothorax, and so many things can be found out by simple ultrasound in the bedside in critical care. And lung scan, funnily, lung is an organ which can never be scanned adequately, and it was very underused. And very interestingly, it doesn't produce the image of the lung, but it produces a lot of artifacts. And very intelligently, people have realized the difference between artifacts produced by a normal lung and a wet lung. And they have shown that A lines and B lines are comet signs, or I don't have time to explain most of the things, but just realize that lung scan uses just the artifacts, the differences in artifacts, and they derive information out of it to assess the fluid in the lung and the volume status. So this is the normal lung where you have this A lines, and these are the B lines or the comet sign. And in a normal lung, the pleural line is glistening and it keeps moving with the respiration. And in pneumothorax, again, it is very useful. The lung is not there, the air is there. So you do a M-mode procedure, you get a stratosphere-like picture. And whenever the lung comes in, you see a beach sand appearance. And this is the IVC ultrasound, the collapsibility in inspiration, and the leg raising test. All these things will help you to assess the volume status. So evaluating breathlessness by lung scan in a critically ill patient can be systematically done by lung scan going by this algorithm. And so I would think that having ultrasound as a OPD instrument and for bedside tool in IP patients and in critical care, and the nephrologist with their adeptness in using it will go a long way. Simply in 5 minutes you can assess the kidney size and find out whether it is acute or chronic renal failure, the echogenicity and the Doppler, fluid status and so on. And there are some people who have learnt even some echocardiography to get more information from ultrasound. And I'm happy that Vail Aravind is here, who has like me, he has an ultrasound in his OPD besides his couch. So my message for young nephrologists is that it's time nephrologists take up ultrasound as a primary examination tool. Familiarity and adeptness with ultrasound is a prerequisite for any aspiring interventional nephrologist. I will tell you that in any of the procedures we discussed today, PD catheter position, tunnel catheter, etc., if you are good in ultrasound, you will be very better off and safer for the patients. And also I believe that innovative new thoughts, findings can evolve only if the clinician is involved with ultrasound. And again, don't go with the idea that you can do away with learned radiologists, because we'll have a tunneled view and you'll see only the kidney and what you want. You will miss so many other things. So it is imperative that you have a radiologist do all these procedures before you try to have a look. Thank you.
Questions for next 3 minutes.
Dr. Balasubramaniam, thank you for a good presentation. Do you think your knowledge of kidney disease of your patient will unnecessarily bias you in giving a diagnosis from ultrasound?
Yeah, to a certain extent it is true, but that should not stop you from say a cardiologist, he is having a look at his own patient's heart, and I don't think that will very unduly distort the truth. See, especially when you are trying to find newer things, maybe you'll be biased because you want to prove something, and you'll have a tendency to, but you can always have a friend or a radiology colleague who can corroborate your findings.
I'm Dr. Virakodi from Teaching Hospital Jaffna, Sri Lanka. You talked about elastography in renal transplants. Now, what was the usual post-transplant period in these transplanted patients? Are they new patients? Are they post-operative or chronic ones?
Yeah, see, actually my initial study was on 50 patients, and many of them are old patients. I didn't have any pre-knowledge or pre-data to guide me, so I had to have a raw data and look at how it behaves. And I ended up thinking that it is more useful in the acute stage, like first 1 or 2 months, where these activities like ATN, acute cellular rejection goes on. And for any chronic rejection and fibrosis, that is not a big deal to find some increase in or decrease in elasticity and increase in stiffness. But this will be very clinically useful in the perioperative period or first 3 months.
Okay. If there aren't any further questions, thank you very much, Dr. Subramaniam.